what I got here is like an overview of novel digital clinical tools in obstructive sleep apnea. So this work was done in collaboration with one of my master's students, that is Miguel. And at the time during my master's and my PhD, my supervisor was always Pedro Pereira Rodrigues. He's a professor in the faculty of medicine. So this is the article that we publish, is a systematic review. Have you ever done any systematic review for your work, or just literature reviews? More literature reviews, okay. So systematic reviews are a topic that I really, really like. So I have one done by my PhD. It's about tools for screening and diagnostics of obstructive sleep apnea. And then I have this one for novel digital cleaning tools, so also related to the screening and the diagnosis of the disease. And now I have two master students, doing one in sleep disorders and infertility in women, and another one that is doing an overview of all the apps that are used to try to diagnose and screening for the sleep disorders also. Like she's searching Google Play and Apple Store and things like that to check all the apps that are available for the screening or diagnosis. So just to give you a little bit context, what is the disease? So obstructive sleep apnea is one of the types of sleep disorders. We have many, many others. Like for instance, you have one that is narcolepsy. Basically, the people has so many sleep, like literally they can be walking or driving. They will simply fall down in the floor because they cannot deal with the amount of sleep that they need to have. We have this one. So sleep apnea can be three types. We have obstructive, central, and mixed. And it depends on the number of the events and the type of the respiratory events that you have during the night. So basically, when you what happens is that in the first figure, you can see normal breathing. So you can see compared to the others that your tongue, basically your tongue is a muscle. And when you fall asleep, your tongue drops into your throat. And normally, if you have a good ability to breathe, and your tongue as a muscle is very functional, and you have a large airway or a normal airway, the last thing will not happen. So your tongue will drop, but it will never stop the flow. When it stops the flow to your lungs, you have the complete sensation of air. So you are really no air is entering your lungs. And what's happening is that your brain will start to give you signs that you are stopping breathing. Basically, the thing that distinguishes an obstructive or mixed or central event is if your lungs are doing the effort or not. So if normally, I will also talk about that, these types of disease are studied and done in the hospital setting, and you perform a sleep study. Okay? There can be four types. You can just like go to the hospital, sleep there, and in the morning you have diagnostics. And even if there is too bad, you will already have a treatment during the night. Basically, it's a machine that gives you air so that your tongue will not obstruct your airway. Basically, it's the machine. And then you can also have type 2s. Type 2s is basically you go to the hospital, you set up everything in the head, in your limbs, in your chin, and in your belly, and then you go home sleeping. And then you have type 3, basically is the same thing. You go there, the technician put all the stuff, but it's less channels for you to analyze, so it's less signals. Then you also go home. And then level 4 basically is oximetry with a type of belt for you to try to distinguish the type of events. So you can distinguish the events with a bang, a thoracic one, and abdominal one. So if you are without breathing, but you still have the movement of that band, is an obstructive event. If you stop breathing and the bands have also stopped, is a central event. And then you can have events that in the beginning you are still making the effort to breathe, but then you stop, and they are mixed events. Okay, basically that's it, the diagnosis. And what happens is like during the night when you are in the hospital or at home, this number of events are counted by hour. So the definition of an hypopnea basically is a partial obstruction of your airway, or an apnea, that is the complete cessation of air. This has to be longer than 10 seconds. Okay, so you have people that have events of the 10-second durations, but then you can have people that stop breathing like during 1 minute, 1 minute and a half, 2 minutes, and so on. Or they can have like smaller events, like 10 at a time, but they have like in 1 hour, like 80 events of 10 seconds each. This is very bad to your body, which could lead to sleep fragmentation. Okay, so you are always waking up, which also will cause that in the morning you feel very tired. Okay, no non-restorative sleep. And then it also means that during the day you will have excessive daytime somnolence, so you feel very somnolent during the day. Also, this disease is very linked to other comorbidities such as hypertension and many other cardiovascular diseases like arrhythmias, coronary arteries, and even several ones, because as you can see, like one of the systems in the early beginnings of this disease is that your brain will notice that your lungs is making the effort, but the oxygen is not reaching the brain. So the brain would tell you like, I'm not getting any oxygen, please wake up and go to the bathroom. That's one of the symptoms. Is you being constantly to the bathroom because it's one way of your brain telling you that please breathe, please wake up. Like you have the urge to go to the bathroom, so wake up. One of the other things that we have is witness apneas. Basically, it's like you are sleeping and then you stop breathing and then your brain tells you like to gasp for air. And so it's also another symptom. So we have many things. Many of them are related to the size of your neck, related to your tongue, and mostly related to the upper airway. So you have also like large tonsils, or if your jaw is like put behind, retognathia or something like that. So it's also can cause you to have this type of disease, okay? And all of this, of course, will result in decrements in the cognitive function. So regarding the study or digital tools that can be used in the screening or diagnosis of the disease. Normal ones, we have things like nasal airflow device. So basically things that you put in your nostrils and you breathe and it will detect the events. Now we have more things like smartwatches, smartphones, ring sensors, even the microphones or the microphone of your smartphone can use to diagnose the disease. Radar device and even sensors putting the below your pillow or under the mattress, okay? So basically they are many, and so we decided that we need to perform a systematic review to identify together and analyze the most accurate ones, okay? So basically that was the objective of this master thesis of my student. So for you to perform a systematic review, you need to search in not just one place, but at least 3. So we search scientific evidence in PubMed. Basically, this is, I don't know if you know PubMed, but it is a database specific for health. So PubMed always. And then we use Web of Science, there's more generic. And then Scopus, which is also more generic. And then as you can see, we created the criteria for inclusion and exclusion. So basically, we only focus on adults with suspected of having the disease or already diagnosed with the disease. And then we check the accuracy of these digital tools for screening or diagnosis and having the gold standard as references. So PSG or polysomnography or level 1, it's the same exam, different names, but the same thing. But we are only comparing articles that compare the results of these digital tools against the gold standard, okay, not the other levels, just the goals. Some of the exclusion criteria: the pediatric population, pregnant woman, because normally the airway is different when a woman is pregnant, so they are also needed to be excluded for this. HSAT basically is level 3 that I already talked to you, less signals and the people go home to sleep. And if just one portion of the article use PSG and another one no, we also exclude it. This was done until November 2022, and we had no restrictions. So we choose any articles, even if they were like in Chinese or Russian or something like that. We found out the translator and we translate everything. So no restriction in the year of publication, the type of the publication, or the. So what we decided is to create 5 categories to put all of these digital tools together. So we have a category for smartphones, another for wearables, bed and under mattress sensors, nasal airflow device, and many, many others like the rings. And so we also decided to check if the article was performing just internal validation, like cross-validation or bootstrapping or something like that, or if they are performing external validation. So if they are using a new population to validate the digital tool. So as you can see, we started with more than 1,000. And then we found out the duplicates, and then we have done the first step of a systematic review, that is analyzing the title and the abstract. And then we have 108 that we exclude. You can see many of them, most of them, 41 was because there was no gold standard compared to the tool. There was 41 studies without the gold standard. So we included 26. And then we have also talked to other authors and checked conference and manual review, and we found out more 15. So in total, this systematic review has 41 studies. So I will show you just the best results for each category. So we have 5, and you can see that the first one is a smartphone that use an app, and the smartphone was used as a sonar device. And then we have a ring in the wearables, under the mask sensor. Then we have the under the nose pressure sensor that is called sleep strap. This is already approved by the FDA. And then we have just a simple audio recorder. Okay, this was the best results. Just to give you another context that I'm missing in the introduction, obstructive sleep apnea is defined by the number of events per hour. And if you have less than 5, then you are normal, so you are healthy. If you have above 5, you have the disease. And then you have categories of severity of the disease. So between 5 and 15, you are light disease, like the light stage of the disease. Then between 15 and 30, it's moderate. And then above 30 is severe. So that's why we also include that column there to see what is the cut point of each of the sensors for the type of the disease. And if you can see the normal values and the assumed values and the values used for every clinician is the ones that is not in the 4th study. So you can see that the 4th study using 10, 20 and 40. And this is basically wrong because this is not the clinical guideline to cutoffs of the disease. It's the previous ones that are the 5, the 15, and the 30. Okay. We also show you there the sample size, also prevalence of the disease. You can see that 2 of the studies does not even report the prevalence of the disease. And then we studied the rock curve, the AUC, and then the sensitivity and the specificity. And so we decided that the best studies will be the one that have a higher AUC, so closer to 100, and then which also has a higher percent of sensitivity and specificity. So this was also in our methodology display. So this is the result. Regarding that, we also wanted to see which one was done as only internal validation and the one that was done external validation. I also will show you here this one. So regarding the best study for internal validation was one from 2014 for Norman. This was under the METS sensor. It reached 100% of AUC, 100% sensitivity, and 96 of specificity for the higher level of the disease that is higher than 30 events per hour. Okay, but as you can see, the also prevalence is 81%. So this is specific to a type of population that is already suspected of having the disease. This is not for the general public, okay? This is people that are already has a suspicion of having the disease. And basically the sensor was a foam mattress, so it was an entire mattress that, aside from recording the breath sounds to identify the respiratory events, it also has pressure sensors that can determine if you are bellying down, bellying up, or laterally. and it generates, like it says, that they generate voltage when deformed, and that way they can classify the loss events. Okay, basically, this is the best one done with internal validation, and it was cross-validation. And then regarding the external results, so it was the simple device, it was an audio recorder, a normal recorder, also for the severity level higher, so above 30. As you can see, no reported on OSA prevalence, and then it reached 99%, 96, and 92. Basically, it records your sound when you are sleeping, and then an algorithm will detect the events, and then you will have the result if you have one. Then we also have done a thing that is the analysis of risk of bias, that is also assessing the systematic review. And you can see that the one that was the auto recorder is the one that has the lowest risk of bias. So it could be replicated by other people, and it was already externally validated. So this is the other recorder is really the best one. I'm sorry. Regarding some limitations, we identify the study designs. Most of them were not described in the original articles. Also, the number of participants were low or even not described. Also, the reasons for performing the polysomnography was also not described. And then, as I said, also prevalence, and then the metrics that we choose was also not described. And then we have the setting and the external validation that many of them was also not described. And you can see it because I'm feeling. So for us, in the conclusion of the systematic review, we think that this review or this device has the potential for the screening and diagnosis of obstructive sleep disease, and that further development is needed, especially for external validation, because we only have a few studies performed external validation. Many of the tools are only developed, so basically they are people that develop the tool but then stopped validating, and the tool is just dropped, so no more research doing on that tool, so we cannot use it. And although this cannot replace the gold standard, of course, like we are not going to replace the physicians or the sleep technician that does this every day, we think that these types of tools can enlarge the screening of the disease, because like you have, all of us, we have a mattress in our house. So if your mattress detects that you have a sleeping problem, maybe we can have already a small amount of data for you to go to the physician with a specific metric, and not just like you think that you sleep bad. So as a conclusion, we did more good quality studies, more robust clinical data, like we all know, like we have a lot of missing information in the diaries of the patients, so we need also more clinical data. We need also strategies to put this as a large screening tool, and again, validation in external populations, and also in home environments. So the idea with this systematic review is that we excluded the ones that was not comparing to the gold standard. So now the idea is to do the same thing and comparing to the ones that is done at home and not in the hospital. So I'm also trying to do this. And basically this was my presentation. So if you have questions or curiosities, feel free to ask, and I try to see if I can answer them.